I make a comment, Dan?
Please do.
Okay, because I happen to be a card investigator and the reviewer for at ESMO, the discussant for Profound. I disagree a little bit, Tanya, on the fact that I never considered shifting from one androgen signal inhibitor to the other as a valid option for our patients. So, and I'm not saying that because, you know, we can disagree and before this data, but when this trial started, I was like, this is a no-brainer study. Why are we doing this study? Right? Well, why are we doing this? This is a waste of our time. Turns out, though, that you're absolutely correct. And still out in practice, a lot of us, even today, after 7 months, we see, even here with an MD Anderson, people shift from one to the other agent. And now we have clear data because if you look at both trials, for me, shifting from one to the other was the equivalent of placebo, the outcomes, right? Within 2-3 months, all patients progressed on both of those, if you look at them carefully. So this is kind of where I'm saying, oh my God, we need to go out there, as you said, and kind of educate more people to not consider as a first thing, let me go from abiraterone to enzalutamide or from enzalutamide to abiraterone, but think about it more. And I think it's more of a Ben question, really, because a lot of these patients, no, not in the sense, because it's harder to do the referral, right? You have to go to a different doctor to do the chemotherapy. And it's also that fact that the old tropic data with cabazitaxel was so scary for a lot of people, 5% toxic deaths, that still, for those of us who use it every day, a lot of us can say, you know, cabazitaxel is so much better than docetaxel. And we got the Firstana data to actually speak to that point. So a lot of things that sometimes we have not processed enough until we actually get into the practice of using it came out of these two trials. The thing about Profound that was a little bit of an issue for a lot of physicians is the fact that it didn't show an overall survival benefit, but 80% of the men who were on the placebo arm were immediately offered within a couple of months to go on to olaparib. So we can't really judge anything from the overall survival data. I was a little bit surprised by the approval across the board, but that was to be expected because one of the things is, as you pointed out, Tanya, it was like largely BRCA2 and 1. And ATM data set is a little bit of a mixed bag of things there. So we need to get better of it. But that was truly groundbreaking because it opens the door immediately for the approval of targeted therapy for prostate cancer. That's the first one. So really that ESMO session was for me pretty important. I mean, for 2019 at least.
Yeah. I would like to point out, that although I'm very enthusiastic about the PARP inhibitors and just as excited as everybody else, it's really important to notice that, despite the presence of somatic BRCA2 alterations, not everybody responded particularly well to these therapies. And when I saw that, I wonder why. And there was some really interesting data that's coming out. Pro-Repair A was a study that was presented at ASCO this year, which looked at the presence of one or more of these alterations. And really, I think this is the next level we're going to get to. Right now, we're thinking, okay, is there BRCA2 mutation? Yes or no? And if there is, great, we've got a PARP inhibitor. And that's true. But when we see RB loss and other genomic alterations, we know we're dealing with a different prognostic category. And so this gets back to what we said earlier, which is, we're beginning to talk in that language about the genomic complexity of the disease, not simply as a mutation present or absence, but about the totality of the biology, which is actually really encouraging and exciting.
Doesn't it also speak, though, Chuck, to your point about tumor volume and heterogeneity? Because all those patients had to fail abiraterone and enzalutamide. They're not only metastatic castration-resistant, they're like one step further. And right. So if you think about like the non-metastatic castrate-resistant setting, if you had somebody with a BRCA2 in that setting, you would imagine that PARP inhibitors would work even better in that setting.
Right, and so if we can attack the BRCA2 altered prostate cancer before it loses P53, if we can do that, before it loses RB1, if we can do that, we're going to see better results. And this, is just the general theme that we're talking about, which is earlier may be better, simpler biology is better, et cetera, et cetera. So I think that the Profound data, while really encouraging, and the rucaparib data also open the door to further questions and opportunities for us.
There's also a lot of interest in combining some of these agents. so, there's this whole question about whether having those mutations also makes you more sensitive to immunotherapy with a checkpoint inhibitor, which we know has performed relatively poorly in prostate cancer in unselected populations. But the olaparib with durvalumab data, I think, are pretty interesting because you wouldn't have necessarily expected to see responses in an unselected population. But, they had a 12-month PFS of 36% in patients without the mutations that you would use to predict sensitivity to the PARP. So, and that's much higher than with checkpoint alone, much higher than you would expect with PARP alone. So is there some synergy there? So I think that's one direction the field is moving, in addition to, the next generation of PARP inhibitors that may have broader effects or differential effects. Olaparib shows some responsiveness with ATM, rucaparib did not. I think we're going to have to really get into the weeds, to Chuck's point, about how complex it is to understand the genomics and the heterogeneity and what that means when we're choosing treatments.
Yeah, it's almost ironic, Tanya, because you're absolutely right. And the irony is that we're also seeing data of the combination of abiraterone and PARP inhibitor, right, is the PROPEL data and others. And there are studies launching that are looking at PARP inhibitors plus AR inhibitors in the unselected patients. So we may be going in the front door saying we're going to do all this genomic selection, have these targeted therapies, and then go out the back door saying you don't need to do that in everybody. So,
but there's one more, because you brought up the very nice experience we had at ASCO. There's one more thing that's coming out for the DDR patients, and again, we don't want to go into the weave, because the profound data went strictly for anything you can pick up. I mean, widely, I would say monoallelic was good to go since they used that specific assay. So, and we had some answers with regard to going for monoallelic coming out for some of the Nature papers that had been published that actually supported that. Some of the other approaches have been more purist, going for biallelic alone. I think we want to walk away a little bit from being so selective moving forward. And the approvals that we got for the FDA are speaking to a specific assay, but maybe we want to comment moving into the future, we might be using other assays as well because cost is an issue and we don't want to be bound. But for now, the approval for olaparib was for a specifically foundation assay, companion diagnostic, and of course the myriad, I believe, for germline assessment. But I wanted to bring up one point that came up from ASCO as well. The fact that it is likely that those men that have tumors that harbor DDR alterations may not be at all responsive to taxanes. And that had come out in a retrospective analysis from Castro et al. But there was a presentation, it was a poster about looking prospectively at such candidates where cabazitaxel really underperformed. It really performed as badly as transitioning from abiraterone to enzalutamide and enzalutamide to abiraterone. So more to look into the future about selection of these types of patients that have these more aggressive phenotypes based on molecular characteristics, I think.